All right. Just wanted to welcome everyone to the Antenatal Fetal Health Surveillance Update webinar. It's great to see such an excellent turnout. I'm seeing about 76 participants on this list at the moment, so that's great, and it's such an important part of our care for pregnant individuals and their families. My name is Michelle Delany, and I'm the Provincial Perinatal Coordinator for Perinatal Services BC. And I just would like to start off this webinar in a good way by gratefully acknowledging that the PSBC head office is situated on the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. We deeply appreciate the Indigenous peoples who have cared for these lands and waters for generations, and recognizing the impact of colonization on Indigenous health, we commit to eradicating racism and decolonizing healthcare. We are privileged to learn from and work alongside Indigenous peoples in this reconciliation journey. This is a gift and an invitation for us to open our hearts and minds to listen, learn, and do our best. For those joining from different parts of Turtle Island, colonially known as Canada, we invite you to take a moment to reflect on the unceded occupied territories and lands you are connecting from. I would like to now just introduce our presenter today. Dr. Kirsten Niles is an obstetrician and gynecologist who is specialized in maternal fetal medicine and clinical genetics. And she is also an author of the SOGC Guideline number 441, Antenatal Fetal Health Surveillance. Prior to joining the Division of Maternal Fetal Medicine in the Fraser Health Authority in BC, she completed a combined MD, PhD at McGill University, residency in obstetrics and gynecology, and fellowships in maternal fetal medicine and clinical genetics at the University of Toronto. Dr. Niles is also the current regional division head for obstetrics at the Fraser Health Authority. And outside of work, she enjoys skiing, dancing, and nature photography. Before I pass on the presentation over to Dr. Niles, I would like just to remind participants to please enter questions in the Q&A chat box during the presentation. We will be monitoring this box throughout the presentation, and we'll leave some time at the end to answer questions. Welcome, and thank you, Kirsten, for presenting to us today, and I will pass over the presentation to you.
Thank you, everyone, and thank you for inviting me to give this presentation. And I appreciate the very first question out of my mouth was going to be, which view do you see? So I'm glad someone already noted it, and I've been able to fix it since. As noted, I am one of the authors of the SOGC guideline, but I will say later I present that I have a team behind this. And so it's not just myself who created this guideline. And so I hope anyone who's on has had an opportunity to read it. And yeah, most of what I'm going to be focusing on is going to try and make sure that I highlight the updates and any clarifications that might be needed. So I also would like to recognize that as a Fraser Health individual, that we provide care on the traditional, ancestral, and unceded territories of the Coast Salish and Nklapamuk nations, and we are also home to the 6 Métis chartered communities. I have no specific conflicts of interest to declare. As with most SOGC guidelines, it was a volunteer basis only. And so really my goal was to just update the guideline. And of course, as regional division head, I have a keen interest in ensuring that this is translated to practice, but it does not influence my representation of this guideline in any way. So as I mentioned, this was a team effort. And so these are the individuals, and we are actually relatively well represented across the country who contributed to this guideline. And you'll recognize some familiar names, certainly from BC. But just in case we have other participants, obviously there are a number of individuals across the country who contributed to this guideline. I also have to thank Sharon Doré, who presented this recently at the in Ontario. And so I did model some of my slides after what she had already created. And of course, she is also quite active in the National Fetal Health Surveillance course. And so any feedback that she's been gathering and that comes from any of these presentations, we are trying to use to incorporate, or she's trying to use along with her group, to incorporate into any future iterations of the antenatal fetal health surveillance or fetal health surveillance certification courses. So really what our primary goals of antenatal fetal health surveillance are to try and detect perinatal risk factors for fetal decompensation, detect fetal decompensation if it's happening, and detect it in a time frame that allows for timely interventions to prevent perinatal morbidity and particularly mortality. The absolute key aspect of all of that is fetal oxygenation. And so without fetal oxygenation, that's really where we get into trouble. And so all of our modalities are actually utilized to identify fetuses that are entering into a low oxygen or hypoxemic environment. And that explains why some things are particularly amenable to fetal monitoring and why some disorders such as cholestasis of pregnancy are not as amenable to monitoring. So fetal oxygenation is a balance between the maternal oxygenation status in her or their blood carrying capacity, the interaction with the placenta and how well the placenta is transiting that oxygen from the pregnant person to the fetus. And then of course, any fetal reasons that oxygenation may be is processed differently. And so all of that is a fine balance that is constantly in flux and is really where we can sometimes see concerns. So most fetuses have some form of an oxygen reserve as part of their placenta or their placental unit, and this allows them to tolerate short-term hypoxic events or short-term blockages of oxygenation. Not all fetuses have that surplus, and so some fetuses begin to build adaptations when they're experiencing impaired gas exchange. And so some of that can be short-term, and this is where we might see fetal heart rate changes. So bradycardia, which allows for increased cardiac filling, or tachycardia or fast heart rate, which allows for increased output to allow more blood to reach the fetal body. If there's a kind of a longer term or a chronic lack of oxygen, we might note that the baby starts to prioritize blood flows to certain organs. And the organs that are most heavily protected are the brain, the heart, and the adrenal glands. And so this is where that cerebral sparing commentary would come from, is that the baby is sending more blood to the brain to allow the brain to continue to develop appropriately. And I always say to families when I meet them, I say the babies are smart. They know that this is what they're supposed to be doing. And so they're protecting their own body. Now, when we start to see problems with this, we might then get end organ asphyxia and dysfunction, and this is particularly true in the midbrain, and that is what results in these altered fetal behaviors. And so altered fetal behaviors include changes in fetal motions or movements, and all of this comes with a gestational age caveat that as the baby matures and the physiology matures, you might see changes in how the baby is expected to behave, the expected blood flows, and of course the expected heart rate patterns. And so that's a theme throughout all of fetal health surveillance, is just understanding what's normal for that gestational age or what's typical for that gestational age. What we do know is that fetuses deteriorate at a generally predictable, in a generally predictable pathway. And so they go through early adaptations, late adaptations, and then eventually warning signs that death or morbidity is imminent. What is difficult to predict is the actual rate of deterioration. And we've all been in those situations where you meet a pregnant person where 1 week the baby's totally fine. The next week the baby's small for gestational, well, 2 weeks later the baby's small for gestational age. The week after the Dopplers are crummy, and within a few days we're talking about urgent or emergent delivery. Versus those pregnant people that come to us at 22 weeks and we watch them until 37 weeks and it's barely a hint of trouble, but actually that baby's fetal placental unit was a problem. And so that's why the frequency of fetal surveillance is somewhat variable. And it's why there's that increased frequency when we're worried about a fetus that may get into trouble. But the frequency is really hard to determine because it may be different for every fetus, it may be different for every risk factor, and certainly any combination of risk factors. And so that's where fetal surveillance really struggles, is to make that kind of clean-cut decision about how frequent or how often. So some of the challenges are that the fetal health surveillance recommendations are founded in basic science because we understand this lack of oxygen in the fetus and how it might cause problems. but we really don't have any high quality research to guide some of our decision making around the modality, the timing and frequency, and who to do these things in. The secondary issue is that these are all indirect assessments of the fetus. And so we're using things like fetal movements or fetal heart rate patterns or ultrasound to try and glean information about how the baby's actually doing without having that direct ability to test the baby. And the kicker of all of this is despite all of these technological tools that we have, all the monitoring and tools that we've instituted to try and protect these babies from the worst case scenario outcome, which is a stillbirth, our rate of stillbirth actually hasn't gone down over the last 20 to 30 years. And it's hard to know if that reflects the causes of stillbirth that are almost unpreventable, so the cord accidents or the acute events, or does this represent babies that we're detecting too late because their deterioration is so rapid that it's falling between our monitoring times, or is that it's just things we don't know or don't know how to prevent? And so that's really the frustrating part of all of this, is that when we're talking to families and saying, well, we recommend this increased frequency of monitoring, they still can show up with a baby without a heartbeat or experience a really adverse outcome. So it's really, really tough. And finally, all of our testing recommendations are based on expert opinion. So really, it's our best guess. And I hate to say that, but it is really truly our best guess based on some good foundation of science, a little bit of knowledge, and a little bit of caution. So we have a lot of surveillance modalities. There are a few that are kind of routine in all pregnancies, and these include antenatal visits with a prenatal provider, of course, the frequency of which can be variable, as well as the perception of fetal movements, because that's available to all pregnant persons. There's also some non-routine monitoring, although some of this is semi-routine. So there's fetal heart rate pattern testings, including non-stress tests and contraction stress tests, as well as ultrasonography. Now, some ultrasonography is routine, such as a detailed anatomical assessment, but anything above and beyond kind of our 2 to 3 ultrasounds in the pregnancy, depending on your local protocols, are considered non-routine. And so that's that monitoring of the fetal growth, amniotic fluid assessments above and beyond the routine visits, biophysical profiles, or Doppler studies. Once again, one of the biggest challenges is that there is no one ideal test for all at-risk fetuses. So when one of the things we did focus on this guideline is the concept of choosing wisely. And so it is really important that when we're identifying fetuses we want to do the testing in, we want to make sure that we're testing at-risk fetuses. So prior to testing, if the fetal chance of hypoxemia is relatively low, there is a much higher chance of a false positive, and that's because the positive predictive value is quite poor. There's an increased chance of unnecessary interventions or increased chance of patient anxiety, and certainly an increased burden on providers and resources. And so it's really important that the use of non-routine antenatal fetal health surveillance modalities should be utilized only in the presence of a clear indication, and that the modality and frequency should be based on the clinical picture, local resources and protocols, and of course, a shared decision-making model with the patient. It's important to understand their level of concern, make sure they understand the reasons that we're recommending the tests that we're recommending, and that the frequency of monitoring is not actually causing them undue stress, with the balance for what's typically recommended based on the protocols or the guidelines of very specific risk factors. So how do we find an at-risk pregnancy? So a lot of this is history-based. When we meet with pregnant people, not just at the first visit, but any subsequent visits, we review the pregnancy history. We review the characteristics, including, for example, their body mass index, or whether they have recreational drug use, or whether there are other concerns within their socioeconomic status that might put them at risk of an adverse event. Additionally, we want to review their health and determine if there's any diagnoses that have been associated with adverse events in pregnancy. At each visit, we want to make sure that we're reassessing the potential risk factors as the pregnancy continues, because of course there are pregnancy-related factors that can cause problems. And when we do identify or assess risk factors, we should document the risk factors that are identified and how this might modify or change our plans, or what our plan is for ongoing surveillance. Within the guideline, there is an appendix that kind of tries to be a bit of a guidance as to what might require more monitoring. But of course, this is never exhaustive, because if you do an exhaustive list, that could be a 30-page document in and of itself. Some of these specific risk factors have guidelines already associated with them. And so those are the overarching information about those particular findings. And some of these other ones might require additional expertise, such as anti-Ro or SSA antibody may require a maternal fetal medicine individual, for example, or additional ultrasound monitoring. So now I'm going to jump into some of the surveillance modalities that we have. So let's start with our prenatal visits. So the two types of prenatal visits include the different people that may be involved. So a family physician, a midwife, obstetrician, or maternal fetal medicine physician. I put that in parentheses because in some provinces, maternal fetal medicine physicians actually also do primary care, and in some provinces they don't. And so it does depend on your local style of practice as to when and how a maternal fetal medicine person might be involved. Family physician can also be someone who's not a perinatal provider at the start and transitions to a perinatal provider, or it may be a perinatal provider from the beginning. Additionally, the modality may be virtual or in person. Virtual definitely came to a forefront during COVID. And so we learned that it is actually a modality that can be utilized, recognizing that there are certain things we cannot do easily over the phone, including things like a symphysis fundal height or our own blood pressure, although many people can do a cuff at home. And so there are some aspects of care that we do need to provide in person, but for some, a virtual visit may be very beneficial. The frequency is incredibly variable. In Canada, we've traditionally had kind of an intake visit at the 12 to 14, somewhere in the first trimester, and then a follow-up visit at 6 to 8 weeks after that. And then once we hit the 26 to 28 week mark, then we start doing every 4 weeks, and then it increases to every 2, and then every 1. That's actually not based on any set of evidence. It's probably a combination of knowledge that as the pregnancy progresses, the potential for adverse events increases. And so you need more frequent touch bases with a pregnant person, as well as where the key tests along the way might be, such as gestational diabetes screening or anatomical assessment or aneuploidy screening. And so each of those visits might be variable depending on your local protocol, as well as your own style of practice. It is important that whatever the local antenatal system is that you at least follow that frequency in general to the best of your ability within reason with what the patient can accommodate. Because of course, if they leave the country for 5 months, you're not going to be able to see them that frequently, and virtual visits really aren't very feasible. And I've already alluded to some of this, that the factors to consider include the gestational age, the risk factors known, and the model of practice. And actually, just before the guideline came out, this beautiful resource called the Michigan Plan for Appropriate Tailored Healthcare and Pregnancy came out that talked about kind of the frequency that might be needed depending on the various considerations in the pregnancy. Now, this is a US resource, and so that does sometimes change how we approach it because we know that the US often is more for profit. There's more insurance concerns, and there is a higher rate of lawsuits. And so this is to be used with a grain of salt, but it is a helpful tool if people want to use that to determine kind of any changes in how they do their antenatal care. With regards to the components, the intake visit or visits, and I've put this in plural because this list is quite extensive, is the history including the medical, family, social, environmental, genetic, and pregnancy-based history. And that in and of itself could be an hour. Initial testing, including recommendations around blood work, conversation around aneuploidy screening and initiating aneuploidy screening if requested, and any ultrasound planning that might be required. Additionally, on physical assessment, you might want to do an initial blood pressure as well as determine if there's any physical concerns, and an initial discussion of expectations and any prenatal education that might be required. Now, for most providers, that is an enormous list, and if you are doing it independently, this sometimes might take more than one visit to get through. Other ways that it can be done is if you are able to provide pamphlets to patients, or you have a nurse or an assistant who can take some of this information down. There are various ways to get all of that into one visit, but sometimes it does require more than one visit. And so we wanted to acknowledge that this is a lot of information to gather and a lot of conversation to have. And so it may occur over more than one visit, and that's okay. At follow-up visits, it's important to do the fetal heart tones, and this did raise a lot of questions when we wrote this specifically in the guideline. Often when you do the fetal heart tones, you are able to assess a fetal heart rate, and if it is rapid or slow, then you may listen for longer and might consider doing additional monitoring. But really the primary goal of this assessment is fetal viability. It is not intended as a fetal status check. It's really just truly saying, is the baby alive at this point in time? And that sounds incredibly cruel, but there's no evidence to suggest that prolonged listens at this setting is actually going to improve outcomes. The symphysis fundal height, which I'll address in a moment, the maternal status, so blood pressure, is really the key piece. Routine urinalysis is not recommended. That was something identified in Choosing Wisely a number of years ago. Of course, if you are suspicious of hypertension or preeclampsia, then a urinalysis for protein might be beneficial, but otherwise it is not recommended to do at routine visits. Additionally, assessment of the pregnant person's weight is not absolutely necessary. Historically, we know that individuals who start with a lower or higher body mass index may have an increased chance of adverse outcomes, and very rapid weight gain in pregnancy has been associated with adverse outcomes, but checking routinely does not seem to alter the course or change the plan for surveillance. Historically, rapid weight gain was actually most likely to be associated with preeclampsia because of the edematous state of the pregnant person carrying the extra fluid. And that's something that a pregnant person might be able to tell you without actually putting them on the scale. So if someone is uncomfortable about their weight gain or prefers not to be weighed, that is an acceptable alternative, just advising them about warning signs of edematous symptoms of preeclampsia. The perception of fetal movement, so ensuring that once they reach 26 weeks, which I will address, that they are paying attention to fetal movements and understand what they should be looking for. Reassessment for any risk factors, so changes to their health concerns in the pregnancy, and then documentation of the assessment and any changes to the surveillance plan. You'll notice that we talk a lot about documentation and communication in this guideline. So the symphysis fundal height, and I took this resource from the Intergrowth 21st website. And so the symphysis fundal height is considered discordant when the measurement differs from gestational age by 3 centimeters or more, or is above the 90th percentile or below the 90th percentile. This is mostly meant to identify those babies at risk of fetal growth restriction. So the lower than 3 centimeters or lower than the 10th percentile is what's thought to be the most critical measurement. But it is reasonable that if this fetus is measuring bigger than expected by the symphysis fundal height, that an ultrasound could be used to assess for a large for gestational age fetus, or a predicted large for gestational age fetus, or polyhydramnios. That is not considered an urgent ultrasound, but it is a reasonable approach. And the resource really is the Intergrowth 21st, which has its own website. And this is the document on how to measure it. So if you have anybody who's unfamiliar with how to do a symphysis fundal height, they have a very nice document on how to do it. It's a one-pager. And this is the drawing from that. Next, I'll move to perception of fetal movements, and I'm going to highlight that this is actually one of the bigger changes in this guideline, and I think it might cause some anxiety for individuals, but really it's an approach that's meant to align with the other national and international guidelines, as well as coming from some of the evidence that we have to date. So what is the benefit of having the pregnant person pay attention to their fetal movements? Well, there's no technology required. You don't need anything special. There's no cost associated with it, meaning that they can do it without having to pay any money or needing to have a visit. It can be assessed at any time, and it's recommended after 26 weeks gestation because that's when it's expected that the fetal movements are occurring frequently enough and with enough amplitude that the pregnant person should be able to perceive them regularly. And it's available to all pregnant individuals. Now, there are some limiting factors. So pregnant individuals feel approximately 40% of fetal movements, which in most cases is plenty. But if there's some other mitigating circumstances, that may actually mean that they feel less than their peers or less than we might typically counsel them as expected. There's many influencing factors, including gestational age, maternal activity if they're distracted at the moment, maternal habitus, previous experience with identifying fetal movements, placental location, amniotic fluid volume, and the number of fetuses, as well as if they happen to be paying attention to the fetal movements at the time of fetal sleep cycle. And not all changes to the fetal movements are associated with hypoxia and or stillbirth. And that alludes to the fetal sleep cycle or the fact that if they've changed position and happen to be kicking into a big pocket of fluid, the pregnant person may not perceive those motions, but they are actually happening at a normal amount. So there are a number of techniques that can be used to monitor or identify fetal movements. Our original methods included 10 movements in 12 hours. I think most of us would scoff at that nowadays. And the last iteration of the guideline in 2007 actually suggested that 6 movements in 2 hours was the minimum amount expected. to suggest fetal well-being. What you'll see is there's a whole bunch of other options in between, some of which don't even include an objective measure per amount of time that can tell you that the baby's status is well. So the average time to attain 10 movements is something in the range of 20 to 30 minutes. And no method based on a Cochrane review has actually demonstrated any superiority. Compliance can vary between different movements, different options. And so depending on how the pregnant person is coping, they can really use any way to assess movements. And some of these just include being aware of the fetal movements in general. For some individuals, they really benefit from a clear objective number per amount of hours. And then in that case, the Liston is still kind of the standard within Canada, and it's often what's used in the methodology in all our patient information. But if a person, and I'll get to this, if a person expresses a concern, what we're trying to move away from is making them always adhere to an objective set of movements per time period, because their concern could be real. And the more important thing is that this actually be further assessed. So one of the challenges we have is the evidence. So if we actually look at the evidence, these are 3 big trials that just recently came out, all of which are looking at fetal movements and their influence on stillbirth. So the AFFIRM trial is probably the oldest of them. And the AFFIRM trial is actually an interesting trial because not only did they have people coming in for reduced fetal movements, but when they showed up, they did a full Cadillac package of evaluation, including a very specialized ultrasound, NST, all sorts of monitoring, and they actually didn't show a reduction in the stillbirth. And what this helps us do is to say that not everybody who walks in the door with reduced fetal movements actually needs an ultrasound, because it probably doesn't actually change the outcome. These are 2 other trials that were done using more patient information to try and encourage them to come in sooner. And I'll address this with a different trial, but one of the things that they have found is that patients often wait more than 24 hours before they come in when they experience reduced fetal movements. And what we might know is that for those babies that are actually truly in trouble, the sooner they come in, the better. How many of us have sat next to a person whose baby is now without a heartbeat, and they said, oh, well, I noticed that there was less movement or no movements yesterday, and they only came in 24 hours later, and may have made 0 difference whatsoever, but in our heads, we're like, what if they'd come in sooner? So that is one of the things we're trying to encourage a bit more. One of the reasons that these trials may not be successful in showing differences are because stillbirth events are extremely rare. And the perception of fetal movements is actually very highly ingrained into pregnancy information packages across the world. And so it is maybe very challenging to identify differences in pregnant individuals who may already be relatively well informed. And so therefore, increased education or increased monitoring is not necessarily going to make a difference. So overall, the summary of these big trials is that education campaigns on the importance of maternal perception of reduced fetal movements and fetal evaluation protocols did not show reduction in the stillbirth rate. Now, I want to point out this one trial. It is a little bit older, but it did actually have a fair number of patients. It was a prospective cohort study, and the intervention was education-based. The number of individuals involved was in the 60,000 range. And they excluded any stillbirths that did not present with reduced fetal movement. So the way they evaluated the population was a little bit different. And the intervention actually resulted in a stillbirth rate reduction from 4.2% to 2.4% in those who were experiencing reduced fetal movement. And the reduction in stillbirth rate overall in the population went from 3 to 2 per 1,000. So this is one of the studies that actually showed a difference. Now, they did note that there was an increased use of ultrasound, but this is also one of the studies that showed a reduced rate in follow-up assessments and admission for induction, although that has been mixed in the studies. Some show increased visits and some show the same or decreased number of visits. And what I want to point out is one of the big differences in the study, and that is this time to contact. So these are one of the significant results, is that people presented more rapidly in the intervention group. And so from what this suggests is that for those babies that are actually in trouble and the movement is our warning sign, the earlier they present, the more likely we are to pick them up and to find them on NST and to be able to intervene in a timely fashion or increase our surveillance appropriately. And so one of the differences in the study is they did do the evaluation of those presenting with reduced fetal movement rather than the whole population. But it does go against some of the other big studies that say that there is no difference in the stillbirth rate, but once again, it's a really challenging outcome to evaluate. And so there probably is still some benefit to suggesting that individuals pay attention to fetal movements and present when there's a concern. So how did we put all this together? So the overall is maternal perception of reduced fetal movements has been associated with adverse outcomes in pregnancy. No advantage of any specific technique for monitoring fetal movements. So any technique people want to do, which is whether it's mind fetalness, fetal awareness, specific kick counts, my apologies, or just general gestalt, all of those are technically considered acceptable. There's mixed evidence regarding the impact of encouraging awareness of fetal movements on prevention of adverse outcomes, and that goes to those studies with the big education campaigns. Recognizing that the internet exists and we all know about baby movements. And then earlier assessment may play a role in reducing stillbirth rates for those where movement signals trouble. The optimal assessment of individuals that present with reduced fetal movements is unclear, and so just trying to take a risk-based approach was how we tried to approach this. So here's the algorithm that we created, where all pregnant individuals are going to be advised to pay attention to fetal movements starting at 26 weeks gestation. And if a person expresses a concern about the fetal movements, that they are advised to present to a local facility as soon as possible. Not the sit down and, count in if, in 24 hours, if everything's okay, then come in. As I said, the objective methods may be helpful for some individuals to know when enough is enough, especially if they struggle to know how much to do. But if even despite a count, they still feel that there's a change in the way that the baby is moving, an assessment is reasonable. And when a person presents, doing an NST and a detailed assessment of the perinatal risk factors, with the algorithm of if it's a normal NST and there's no risk factors, they can return to routine care. If they have a normal NST, but they have known risk factors, or there's a concern for fetal growth restriction or oligohydramnios, then consider attempting to get an ultrasound within 24 hours, ideally for a fluid level and growth if it's not been done in the last 2 weeks. I recognize that some centers are not able to do within 24 hours. And so in those instances, something like a repeat NST the next day, if the fetal movements are not good until an ultrasound can be obtained, is reasonable. This is not a reason to call someone in the middle of the night. If the NST is abnormal, we know what to do with that. If the NST is normal, then ultrasound can be done the next day or the day after. And then an atypical abnormal NST, that's when we consider admission for hospital admission or additional surveillance. And using this information to determine the next steps. Now, there's always variations in all of this, including the people who struggle with not feeling movements regularly at all. And those are really kind of a case-by-case basis. And I will emphasize that the absolute most important aspect is that the primary provider be alerted to the fact that their patient presented for assessment for reduced fetal movements. Because as we all know, not all patients are aware of or disclose all the risk factors. And so what we may think is a no risk factor pregnancy may actually have multiple risk factors, and the perinatal provider is aware of that. So it's really important that we communicate back to the perinatal provider that their patient presented and let them assess if additional testing is needed as well. Fetal heart rate monitoring. So this is another big one. And this one may raise some questions, but I'll try and highlight the kind of the intent and the changes that we instituted. So there's 2 forms of fetal heart rate monitoring. There's the non-stress test and a contraction stress test. And so a non-stress test is really meant to be in the context of little to no uterine activity, and certainly no labor-like uterine activity. And so this is a non-invasive tool that's relatively easy to perform, and it must be performed in the absence of significant uterine activity. Now, we did put in terminology for how to interpret an NST when there's no uterine activity, but also how to interpret an NST when there is mild or light uterine activity, but not to the point of significant palpation or significant pain for the pregnant person. It's interpreted using gestational age criteria. And it is interpreted using gestational age criteria. The contraction stress test, is rarely used clinically anymore. And this is particularly because ultrasound has been able to replace it in understanding how a fetus is doing. Where it may still be helpful is if you're attempting to consider induction of labor and you're uncertain if the fetus will tolerate it and you don't want to put the patient through a 5-day cervidil experience and then determine that the baby won't tolerate the labor, or even a Foley catheter, for example, which is a more gentle way to induce a baby that's at risk, you may want to try a contraction stress test before starting labor. I personally am of the ilk that says, well, start it. And if the baby gets into trouble, they get into trouble. But now at least you're partway there. But every program will have a different way of approaching this. But this is why this is a very, very, very tiny portion of the guideline. NST evidence, we don't have a ton, but the rate of stillbirth within a week after normal NST is thought to be about 1.9 per 1,000, which has a negative predictive value of 99.8%. The caveat to this is in any babies that do not have a known anomaly and no clear imminent risk of a problem. So this is not in the baby with intermittent absent end-diastolic flow, for example. This is really in those that you're doing kind of routine surveillance on. There's no evidence of improved perinatal outcomes when actually using NST at regular intervals, but the problem is these are based on very generalized studies and not actually looking at any specific medical context. And then there's additional tools since the original introduction, particularly ultrasound, that has changed its utility because those can be paired together, or sometimes ultrasound can be used instead. And so they don't always have to go hand in hand. And so NST evidence is really lacking, but it's completely ingrained in our practice now. And it is a tool that we can use to assess fetal status. So when do we use it? It is often the initial test in low-risk patients that are presenting with a concern in triage, for example, like decreased fetal movements, a fall or trauma, or vaginal bleeding. It's also used for high-risk patients requiring more frequent fetal assessments to determine how they are coping with any sign or look for any warning signs of worsening hypoxemia. The frequency is really based on the clinical picture and local practices. And for example, the ACOG guideline actually went into itty-bitty detail about how frequently you should do this without much evidence behind it. So we didn't try and take that tact in our guideline. What more is that there are specific guidelines for the most common medical conditions, and the rest is really kind of a local protocol or in conversation with the team and medical experts. And typically it's reasonable to start them at or after 32 weeks of gestational age, although in some scenarios it may be reasonable to start it sooner, for example, in growth restriction. And so that may be offered as early as delivery might be indicated for fetal indication. So really at the threshold of viability. But once again, it's really important to know that gestational age specific criteria varies, particularly in the very early gestational ages. So even though there's criteria for less than 32 weeks, a 24, 25 weeker often has more variable decelerations, for example, just because of the way they're moving. And so it's important to be aware of those differences. Most of us are familiar with the method, so I'm not going to spend too much time on this. This will come up in the graph that I show shortly, but just being aware that the maximum duration has changed a little bit, and we'll explain that momentarily. And the other thing is that there's a technical bulletin on interference from maternal heart rate or other fetal heart rates within the abdomen. And just to be aware of that, that's part of the criteria for interpreting an NST. This is our interpretation chart. It's in the guideline, it's printed, I promise, but I want to draw your attention to these two sections. The first is that, as I mentioned, we've put in a bit of terminology around decelerations or drops from baseline that aren't related to uterine activity. And that is really to acknowledge that an NST should be done in the context of little to no uterine activity, and certainly not in the context of uterine activity that's causing discomfort to the pregnant person or is palpating as at moderate to strong. And so therefore we've used these non-repetitive, uncomplicated variable decelerations as terminology, or episodic gradual decelerations to represent what normally would be considered a late deceleration, but late implies that it's after uterine activity, or recurrent decelerations. Now, one of the challenges is how to interpret repetitive or recurrent when there's no time frame attached to it. And so the time frame is similar to the acceleration criteria as it stands right now, although this is one of the points that we'll need to ensure to clarify. The second bit that I want to draw your, my apologies. The second bit that I want to draw your attention to is the time frames that are placed here. So accelerations, and this is an acknowledgement of the fetal sleep cycle, which can be of a duration of up to 40 to 50 minutes and sometimes even longer, is that we now expect accelerations to occur with 2 within a 40-minute period, and you can watch for up to 80 minutes. So as long as you've got 2 accelerations within a 40-minute window anywhere during that time, then that is considered normal. Anything fewer than 2 accelerations within a 40-minute period is considered atypical, and then abnormal is if you get no or only 1 acceleration in that 80-minute time frame. I acknowledge that this means that not all outpatient NST facilities will be able to accommodate appointment lengths of 80 minutes. And so you may need to have local cutoff criteria to say if after 40 minutes we've been unsuccessful, we may need to shift them to the hospital unit as we've already been doing. But this is really to acknowledge that a baby can sleep, and if we just happen to catch them at the start of their sleep cycle, it may take us some time to obtain those accelerations. So this is one of the big changes within the guideline as well. Last but not least, I'm just going to talk a little bit about my favorite thing, sonography. So the pros of sonography are that you can get real-time observation of fetal behaviors. You can also do a more direct assessment of the fetal placental vascular physiology without sticking a needle into anywhere or trying to deliver a baby. And you can do a semi-quantitative assessment of amniotic fluid, which gives you a little bit of an idea about the renal status and the blood flow to the kidneys, which can be reduced in chronic hypoxemia. And finally, it gives you the opportunity to monitor the fetal growth and identify any atypical growth, either large for gestational age fetuses or fetal growth restricted fetuses. And finally, it's non-invasive, although I've definitely had people try and tell me that ultrasound can cause problems, but it is a very, 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 and I can't emphasize that enough, safe modality. So some of the cons are that evidence comes once again from observational studies. We really don't have a lot of opportunities to do the standard or gold standard versions of studies in obstetrics. And that means we often have to use expert knowledge and observation and extrapolation of studies. It requires expertise or facility access. And that is one of the biggest challenges for ultrasound, certainly in British Columbia, but not just in British Columbia, across the country in general, and certainly in rural or remote regions. It is unclear regarding the most effective frequency, and so we don't know how often we should be scanning people in certain scenarios. Sorry. And ultrasound has the possibility to do a number of things. So, of course, you can do an anatomical assessment that's addressed in a separate guideline. You can estimate the fetal weight. You can evaluate the amniotic fluid. You can do a biophysical profile, or you can do Doppler studies. And this was also not addressed in this guideline because my understanding is there is another guideline coming out about this, and that is definitely kind of above and beyond and is in a different realm of expertise. So this is what we can do with growth in amniotic fluid. So I don't know why that showed up there. We'll just do this. So growth should be measured no frequently than about every 14 days. And that's because that's the range of error. And so when we're in the later gestations, the plus or minus on the estimated fetal weight is somewhere in the range of 300 to 500 grams, which is actually the amount of growth you might expect in a fetus over about approximately 2 weeks. And so therefore the frequency is recommended to be approximately every 14 days because otherwise you don't know what's actually happening. When assessing amniotic fluid, there are 2 techniques. It can either be measured by a single deepest pocket of at least 1 centimeter wide, which is what I'm demonstrating here, or you can do an amniotic fluid index, which is a total of 4 quadrants added together. The most effective method for diagnosing oligohydramnios is using the single deepest pocket mechanism, where the single deepest pocket is less than 2 centimeters by 1 centimeter wide. Polyhydramnios is a bit more challenging. So a single deepest pocket greater than 8 centimeters can be used as a screening tool to determine then that the amniotic fluid needs to be measured with the 4-quadrant method. The reason for this is, and I tell this to my patients, is that it's like being in a bathtub. If you curl up your arms and legs in the bathtub, that end of the bathtub that you're not in looks like it's got tons of water in it, but actually it's just your position that's influencing that pocket. If, however, you starfish in the bathtub, then it's actually going to look like a normal amount of fluid. And so the same goes for the fetus. If the fetus has opted to curl up their hands and feet, and they've left you with a really massive pocket, that may actually be normal when you take over the whole volume. And so if an ultrasound facility says it's polyhydramnios based on a single deepest pocket, it is important to ask them for an amniotic fluid index to determine whether or not we do really see polyhydramnios or not. The biophysical profile, there's 2 types. The first is the standard biophysical profile, which is scored on a score of 8 or 10. It depends on whether or not an NST is added. So an NST can add an additional 2 points to the score of 8, which is based on ultrasound findings exclusively. If a biophysical profile is 8 on 8, then no need for an NST. The false negative rate is about 0.6 per 1,000, and the false positive rate is about 50 per 100, which is why a lot of these things are modalities that are used in conjunction with each other, or it's why it's important not to do these tests in individuals that are considered low risk. The modified BPP is used a bit more frequently in British Columbia because it's easier to do and requires less expertise because you don't need to understand the expected fetal movements or how to watch for fetal breathing motions. And it's not scored, but the two components are a fluid pocket measured by single deepest pocket and an NST. And it actually has a very similar performance to the full biophysical profile with a false negative rate of about 0.8 per 1,000 and a false positive rate of about 60 per 100. And so this, because it's easier to access, is what a lot of BC uses, and it's a very reasonable approach to doing a quote unquote biophysical profile. Now, the challenge is please do not order a biophysical profile because you'll get your ultrasound facility saying we don't know how to do that. Or they'll try and do it and they'll score it as a 5 on 8, which I have seen, or I've seen a 7 on 8, which is not possible because everything has 2 points associated with it. So really what you want to ask for is a fluid pocket or a fluid assessment, and that they will feel comfortable doing. These are the components of a biophysical profile, and the change here, and this is more for ultrasound facilities to be aware of, is that the single deepest pocket used to be 2 by 2, as many of us learned, but we've actually aligned it with the single deepest pocket criteria for oligohydramnios and aligning with some of the other national guidelines where it's now a single deepest pocket of 2 by 1. So everything is the same as the single deepest pocket for determining oligohydramnios or a low fluid volume. And depending on the score we get, it may have different implications for how we should respond. And so this table kind of gives us a bit of a guide. Abnormal fluid being one of the more concerning findings because that does suggest fetal compromise. And this is in the assumption that the membranes are intact. So one final note, and then I'll open the floor up, is that it's important to ensure that adequate pathways for communication, particularly when patient status changes or they present for assessment in the hospital. And this is probably the most important. I find it very embarrassing when someone comes in and tells me that they've been in the hospital and I wasn't aware of it. And I think everybody feels that same experience. And so it's really important that if someone presents with a concern that requires follow-up, that there's a clear pathway to communicate that concern back to the providers. And interprofessional team communication documentation should be clear using accepted and defined terminology. And to ensure patient safety, there should be clear local protocols. These are some of the recommendations that were in this guideline. So to summarize, the major changes in practice are that the symphysis fundal height should be considered abnormally low when it's greater than 3 centimeters behind gestational age or below the 10th percentile based on the Intergrowth 21st project. All pregnant individuals should be advised to regularly monitor fetal movements from 26 weeks gestation and should be advised to present immediately for further assessment if reduced fetal movements are suspected, regardless of the technique they're using to monitor fetal movements. A single deepest pocket of greater than 2 by 1 centimeter on transabdominal sonography for the amniotic fluid component of biophysical profile. And finally, antenatal fetal health surveillance modalities such as NST, BPP, or Doppler sonography should only be used when risk factors have been identified. The key messages from the guideline were that it should be used with the whole clinical picture, including risk factors and shared decision-making model. That all of these modalities assess fetuses at single points in time and may have poor predictive values for ongoing fetal well-being, which is why sometimes we recommend increased frequency. And finally, it's really important to develop clear regional protocols for testing, consultation, transfer of care, and communication based on resource availability. And that is all I had.
Great. Thank you, Kirsten, for this excellent, informative presentation. I certainly have had lots of my questions answered throughout the presentation. Please continue to enter questions in the Q&A chat if you have them and you have a moment to reflect on this content. And we will try to get through as many as we can, but hopefully if we don't get to your question, that we will, Fetal Health Surveillance Canada is working on a Q&A sheet in combination and alignment with the authors. So we'll hopefully have your answers to your questions there as well. But I do see a couple here. When bringing this guideline forward to staff, I've had some nurses asking if a patient comes in for a scheduled NST, but there are regular contractions, but they are mild and not felt by the patient. When documenting, is this still an NST, like or fetal heart rate tracing in the presence of contractions not palpated, mild, and not felt by patient? So it's basically the documentation. How would you document that?
Yeah, so this is what we've learned is one of the clarifying points that we need to ensure is communicated out. And I know that this is being worked on. Within the intent of indicating that it's without uterine activity was really with the intent to indicate that it's not labor, not regular contraction, so not significant uterine activity. And so really the thought is if it's mild, the patient's not feeling it, and it's barely palpable, that is still considered an NST. There is criteria within the NST box that allows for timing associated with or without uterine activity, so that it allows for the interpretation in those situations where there's mild or little to no uterine activity, or the patient doesn't feel it, but there's still decelerations or changes to the fetal heart rate associated or timed with those uterine with what we see on TOCO as uterine activity. And so it allows for either of those. So if the patient's not feeling it or barely feeling it, or it's palpating as mild, it is still considered an NST. And that's the interpretation I think we're trying to figure out the best way to communicate, recognizing that it is just kind of in that borderline. That being said, the interpartum criteria is not all that different in terms of the interpretation of the contraction, the timing of decelerations, and actually a lot of the definitions were utilized from the interpartum criteria, and that was meant to be aligned, but this is the sticking point. And so we are working on an update or some form of a technical bulletin or something to try and clarify that further, recognizing that it is kind of the bit of confusion. I hope I've answered that as best I can, knowing that we're working on it, and I don't want to misspeak necessarily, but it does seem to be the sticky point. But the idea is that it was intended to really point out uterine activity that's kind of normal, like a Braxton Hicks type uterine activity, even if it's got a more regular pattern to it, versus labor style contraction in uterine activity.
Okay, thank you. Yeah, the next two questions you may have answered just in that, but just clarifying what is considered repetitive and recurrent in the absence of uterine contractions.
That's a really good question. And this is, I had someone who emailed me this question as well. So obviously in the context of uterine contractions, or uterine activity, it's pretty clear because it's over 3 contractions or 3 in a row. That's the definition of repetitive, is 3 in the row. Recurrent and repetitive without uterine activity, we didn't actually put a timeline within. So that's one of the things we have to do. And what my reasonable side came up with is if it's happening more than 3 times in the window of 40 minutes. So still within that same window that we use for accelerations. And so if we're seeing 3 variables or 3 shallow things that look a little bit like lates, then that would be considered sufficient. But this is another point of clarification that we'll need to put in, because we didn't actually, repetitive means 3 in a row, but 3 in a row of what? And so that was one of the concerns that was raised afterwards.
Great, thanks. So next question is on complicated decelerations. It says in the bottom of the classification NST chart, it describes the deceleration criteria. It describes the complicated decelerations as well as the uncomplicated variable. Is it a possibility to have complicated decelerations in an NST when there's not supposed to be labor-like contractions?
Some of that criteria is related to the amount of time for recovery. So I'm just pulling it up. So some of that is related to the overall appearance and duration. And so variables are things that are not necessarily always timed with contractions. And so a variable is still the appearance of a deceleration, and the complicated variables have associated with like later more than 60 seconds or more than 60 beats below baseline. And all of those can occur in the context of no uterine activity. So that definition is not any different.
Thank you. So the next question, it says for NST charting with no accelerations within the first 20 minutes, what would be the classification? Atypical and then continue NST?
So you could say atypical for accelerations, but I would put a note saying that due to resources or due to time limitations, there wasn't enough time. Now, previously it was that the NST had to be run for at least 20 minutes, and I think the maximum was approximately 40 minutes. And so most facilities should already have that kind of in their capacity to allow for more time. And so my hesitation would be, we don't expect the NST to be normal within 20 minutes. And so if it's 40 minutes, then usually what our group does is we say it's atypical for lack of accelerations, but they make a note that the duration was not possible due to resources and that they were sent in for a longer NST to see if they would meet criteria when more time was allowed. I think that answers the question, but I could be wrong.
Hey, and there's just lots of thank yous for the guideline. And then Sharon Dorr did mention that Kaplan is working on a template for a patient education field movement sheet coming soon. So I see, Vanessa, you have your hand raised.
Yeah, and I have to say Sharon's doing a ton of work on this in the background, so I'm sure she's listening to these comments and using them to help build our clarifications that we're working on. So I just have to shout out to her again, because she really represents the nurse mindset on our guideline. And I think we sometimes approach NST and surveillance in a different way depending on our background. And so she's really been helping to translate this to the day-to-day practice for us. Sorry, continue.
So there's just one last question I see here is, could there be a baseline abnormality as well as making D cells complicated?
I think that's Tanya is kind of responding to the complicated variable comment earlier, but I could be wrong, because that is true from the definition.
Correct. Yeah. That's great. Well, thank you again for presenting to us. And I just wanted to let people know that we have recorded this presentation. So for fetal health surveillance instructors that are going to be learning this new content, it will be posted on our perinatal and newborn health hub at PSBC for updates there and for viewing later. We really appreciate your time, Kirsten, and thank you for everyone for joining.